So I'm Rachel. I work as part of the multidisciplinary care team over at UC Davis, and I'm going to touch on the current best practices for physical therapy. Let's see. There we go. So just some objectives for the talk as far as just giving a broad understanding of what the role for physical therapy is and differentiating between the different models of therapy. And then really you're going to hear me kind of harp on a home program. And so you'll hear that throughout and why that's important. So physical therapists, we're looked at as the movement experts. And so our role is really just to optimize quality of life. And we do that in a number of ways. A lot of that is education, it's through intervention, and just collaborating with the patients that we see. So more specific to Duchenne muscular dystrophy, the physical therapy role, one that's really important as part of that multidisciplinary care team is completing standardized assessments. And so doing that, sometimes it'll be done through research, sometimes it'll be done in clinic visits, but that should be done at about every 4 to 6 months. Another really key piece is, again, that stretching program, and part of that carries over into trying our best to prevent any kind of contractures from developing. Exercise is also important for this population, and so our role is, as the experts in that, is to really guide families in what's the best way to perform exercise in a safe manner. And then also some equipment recommendations, and then doing all of this in a really timely and anticipatory manner. So looking at this diagram, this is really just to highlight the fact that we're not, we're all just a part of this greater team. Oops, went a little forward. I don't know where it jumped to. Okay, so we're part of this greater team, and we're just one piece of that, with really our patients and their families being at the center of it. And so thinking of that as our approach to physical therapy moves forward. So as far as the role of physical therapy, that's going to evolve as we progress through the various stages of Duchenne's muscular dystrophy. And so there's 5 stages that have been defined, and there's not necessarily age-specific stages. It's more so based on function. And the function, the picture there really just is to highlight that it's related to the progression of muscle weakness that we see. And so our role as therapists is going to change as that changes. The other piece that's going to change our role as therapists is what setting we're providing therapy in. So we have the more of like the rehab or intervention-based model, and that's when you are seeing your therapist either in a school setting or an outpatient clinic. Perhaps it's at a medical therapy unit. And that's where you're seeing that therapist. They are working one-on-one with you, maybe on a weekly basis. They're providing interventions, so whether that's stretching or exercise, and that can be continued throughout the lifespan. It may not be, continuously. It might be bursts of 6 to 12 visits. You take a break, and then you start back up again. The other model is more assessment-based, and that's the role of the physical therapist in the multidisciplinary clinic setting. And that's, again, where we're looking more assessment-based. So we're performing tests, we're monitoring progress, we're maybe acting as kind of the quarterback and making recommendations for referrals to the community for equipment or ongoing therapy. So kind of going back to that thought of the different stages. So stage 1 is really at the time of diagnosis or just before diagnosis, and that is where you may or may not see early motor symptoms, and you're going to see that as perhaps like a delay in achieving normal milestones. And really the role of physical therapy at that stage is really to perform some baseline assessments. So the test that's written up there is the Bailey. That's just one example of a standardized test where we're looking at the development of a child. And so that might be something that is performed during this very early stage. The other piece is education, so talking with families, educating them on how that role of physical therapy is going to change throughout the lifespan, and then if there is a need for referrals, putting forward those recommendations. Then we move on to the second stage, which is early ambulatory. And so typically this is around childhood, and that's a really broad time frame, but because this is changing as new research and therapies become available. So at this stage, we're looking at more of those classic signs of Duchenne's muscular dystrophy in terms of motor function. So this might be where boys start having trouble lifting their head if they're laying on their back. They might become a little bit more clumsy with walking and running, or having trouble with climbing stairs, jumping, some of those motor skills. And then this next picture just depicts what we call as a Gowers maneuver. And this is really typical of how our boys might work on getting up to standing from the floor. And the key thing to look at is that they're really bracing on themselves to stand up. So they're using their hands, pushing up from the floor, and then actually bracing on their own body to maintain their balance as they come upright. And all of this is related directly to that progression of muscle weakness. So muscle weakness develops typically more proximal, so closer to the trunk, and then it expands more distal, so into the limbs. And primarily we see it in the lower extremity and then the upper extremity. And so that's why we see these more typical movement patterns. In this stage, this might actually be your first introduction to physical therapy as part of your treatment team. And this is where that implementation of a home program is going to start. And the focus will be, or should be, on stretching. And they might start a stretching program before you have any tightness or any loss in range of motion. And it's really to just establish that as kind of the standard moving forward. So stage 3 is late ambulatory, and you'll see there it runs the span of childhood up to young adult. And again, that's because this is changing. It's hard to pinpoint a direct age. At this stage, walking and motor skills become more and more difficult. The role of physical therapy is going to expand. We're going to continue to work on that home program. At this point is when we might start to recommend various equipment options to help with things like getting around. So on the school campus, maybe now it's time to try out an adaptive stroller or a manual wheelchair. The other piece that's important is promoting weight bearing and standing. And so this can be done during therapy sessions or with equipment. And this becomes increasingly important because we want to promote bone health. You don't maintain strong bones if you're not using them. And so that's where standing, even if walking is difficult, is still important. And maintaining that weight-bearing position is still important. And again, that home program. So it should be daily. And when we say daily, real life dictates that maybe that turns into 4 to 6 days a week. But as close to daily as possible is going to be best. And wherever you can encourage the child to perform as much of that on their own is the best as well. Moving on, stage 4 is the early non-ambulatory, and again, it spans the same age ranges. And this is where things are continuing to progressively get more difficult, and again, it's correlated to that loss in muscle function. And so this is where really we're transitioning into that stage of using wheelchairs or power wheelchairs for walking, especially those longer distances. And therapy here, again, is that home program. So initially, we're working on stretching the lower extremities. So ankle is one probably a lot of people are familiar with, hips and knees. Now in the stage 4, we're bringing in some other muscle groups. And so it's going to be your upper extremity. And that relates back to where I touched on that the weakness tends to occur in lower extremities first and then upper. So now we're adding on stretches for the upper extremity as well. At this stage, even though a child or young adult might not be walking, it's still important to monitor foot positioning. And so a lot of families might decide at this point they're going to drop off on foot stretches or lower extremity stretches, but it's still really important Without that piece, you can run the risk of developing contractures, which can be painful and uncomfortable. And then it's also limiting to different positioning in a wheelchair or performing transfers. And then footwear, it limits what our boys can wear. So we want them to continue to thrive as best they can. Stage 5 is really that late non-ambulatory stage, and this is more of our adult population, where we continue to see that progression of weakness, and now we're seeing it impacting the core. And really here, we're working to maintain postures as therapists. So in this stage, and all along really, but collaboration with your therapist is really important. So being able to express what your son's goals are, what their desired level of independence is really, really important, because that will help guide what our role transitions into. And this here, where it says occupational therapy may now be needed, this is just based on the current best care practice document, but really occupational therapy might be included in this treatment plan all from the start. So wanted to go back and talk about in the assessment model. So what are we assessing? We've done kind of a big overview of the stages and how therapy relates to each of those. So looking at those assessments, and this is done throughout the lifespan across all of those 5 stages. Things that we're looking at are strength, range of motion, specific time tests, and the reason those are performed is because the timing that a child is able to perform each of these skills in has a relationship between prediction of when they may or may not lose their ambulation in the next 12 months. Specifically at 7 years old, there's certain time cutoffs from 7 forward that are predictive in when they are going to lose ambulation. So that's why these set of tests are performed. And you'll become familiar with them. We do them early so that kids are familiar with them as well, and it's easier to get them done in a clinic setting. And then quality of life and participation are also monitored. So we'll ask about, what you enjoy, what is it you like to do, and that's all part of this. So now looking at the intervention, I just want to dive a little deeper into that and explain some of the things in more detail. So some interventions are going to include the range of motion, just exercise in general, and then stretching. And we look at those 2 things as different. So range of motion is really at the joint, and stretching is trying to affect muscle and tendons. So go a little further. So as far as range of motion, we're really looking to prevent or minimize the development of contractures. And this, again, is that daily stretching program. So this is where you might be helping to perform the stretches. And this, again, we want to implement this before there's a loss in range of motion. The ankle, knee, and hip are kind of the gold standard to start off with. And these are things, again, we want, because we're starting them before there's a loss, a lot of them we can ask these boys to do on their own. Or find the strategies for them to be able to do them as independently as possible. We're also trying to decrease the impact of gravity. So in terms of the development of contractures, that's where positioning is important. So we want to make sure that posture is monitored, and then also optimizing body mechanics. As far as exercise and activity, so it is okay to encourage exercise. You want to be consistent with it, and it should be performed at like a sub-maximal level. So you don't want to perform an activity or exercise to a point where you're feeling fatigue or exhaustion. And you want to use techniques for energy conservation, so some way of establishing a monitoring process. And encouraging rest, and most importantly is to have fun. Swimming and cycling are really highly recommended. We say swimming, it's not swimming laps, but it might be more of like warm water pool therapy. Cycling, we're not talking about cycling, going out for a bike ride down the road, but it might be using adaptive cycles in more of a fun setting. Dance is also encouraged if you want to find something that's enjoyable to your child, and starting that early and then adapting it along the way so that they can continue. What you do not want to do is perform high resistance exercises. So a lot of parents will ask, well, my child they're weak. Can we work on strengthening that particular muscle? The answer is no, because you don't want to cause further damage. Once that muscle fiber is damaged and it dies off, then you get fibrotic changes, and resistance exercises can actually make that process faster. Again, with eccentric movements, so that's like a slow lowering. So if you're doing a bicep curl and you had a weight in your hand, you don't want to focus on that slow lowering, because again, that's a really high demand on the muscle group, so you want to avoid that. And then again, do not exercise to a point of fatigue or overexertion. And this is why a physical therapist who's familiar with Duchenne's is your go-to for determining what kind of exercise to do. You don't want to just go to a personal trainer or someone who doesn't have that knowledge. These are some pictures of examples of stretching. So you'll notice at this stage, he's doing most of this on his own, and those top ankle stretches, she's really there to kind of guide that he's keeping his heel down. These are just an example of various stretches that you might see. So over on the left side, that's for lower extremity, and then more on the right side is upper extremity. So these are things that will be taught. We might have handouts, we can do pictures. There's all kinds of ways of making sure that this is done consistently. This is just a link here to Cure Duchenne. They actually have some really great handouts on different exercises that are easy to follow, and they go by body part. So it's a nice resource for parents if you're confused on a stretch. That's a great website to check out. We also make recommendations for bracing and orthotics. And the goal, again, you're going to hear it over and over, is to prevent contractures and deformity. The one folks are most familiar with is we call it the AFO, the ankle foot orthosis, or a night splint for your ankles. We also have them for knees, hips, wrists, and hands. So the reason I have this video game controller is later in those, stage 4 and 5, where you probably already have the ankle brace or the ankle orthotic. Now we're looking at adding something for hands and wrists. Most boys they don't want it. It's kind of like wearing a boxing glove, but that's important because it allows you to maintain some of those activities that they enjoy doing, like video games, whether they're in college and they're attending courses, so you can continue with typing, controlling a wheelchair. So there's a lot of good functional reasons why this is important. And these are just some pictures to give some examples. So over on the left, you'll see an AFO. The one below, we call that an SMO. That would be more utilized when a child is still standing and walking. That hand one, that's what I'm talking about. It's really cumbersome. It's not fun to wear, but it is important. And then over on the far right is a brace that is sometimes used to help with the scoliosis, so a curve in the spine. Another key piece is really safety. So we're kind of the safety police. We want to make sure our kids are safe when they're doing transfers, when they're on the playground, and our goal is really to minimize fall risk and then to teach proper body mechanics and provide various types of equipment that are going to keep you safe. And again, it goes back to bone health. So as bone health deteriorates, we want to make sure even more so that we're preventing falls, because with every fall, there's potential for a broken bone, there's potential for a head injury, and then you're adding problems on top of problems. So just some considerations. Again, it's just being safe. So, and this is something that your therapist will work with you on as far as determining what's going to best support you and your child with the types of transfers you have to do throughout the day, whether that's on and off a school bus, in and out of a bathtub, in and out of a wheelchair. And so there's a lot of different factors that come into play that we can assist with. And just some equipment, so slide boards, the Hoyer lift, and then that's an example of a transfer chair for a tub or shower. Seating is another role that we are really familiar with as far as wheelchairs. I'll show you some examples and talk through them. So we will help to make recommendations as far as what is the ideal seating system for your child at what stage. And so you'll see on the left is more of an adaptive stroller that's early on, and we want to keep in mind the child's age. We don't want to recommend this for someone who's 10. This is for our younger boys. And then lightweight manual chairs where they're able to self-propel. So again, as independent as possible. There's also options for power scooters and power wheelchairs. This power wheelchair here actually has an option for eye level where the chair can rise up and be eye level with someone who's standing. There's a lot of different options out there, and so we're really helping to guide what's going to be the best fit for your child. So just some other considerations that physical therapists take into their role is maximizing participation throughout the lifespan, really being a piece of that team, so not just the medical team, but also with the family. You guys are at the center, and that's really where our focus is. We can also act as advocates for you, whether that's to help access various funding or find resources. And then also, I don't want to leave this off, pain and pain prevention and management, because a lot of these changes can cause pain, and sometimes your physical therapist can be the person who will help to address that. And as future, as we look at more technology advancements, our hope is that physical therapy will be able to augment that and continue to improve independence, participation, and quality of life. And then the medical therapies, and with this we're talking about some of those gene therapies, some of the research that's coming out. The hope is that will continue to improve exercise capacity, safety with exercise, and overall quality of life. So this is something our role will hopefully expand as these expand as well. And that's it.